Buenos días a todos, bienvenidos al webinar Child Life en tiempos de COVID-19, en vivo desde Nueva York. Yo soy María Fernanda Busqueta, soy directora del Centro de Estudios Psicosociales aplicados a la salud, CENEPAS. Para quienes no me conocen, soy psicóloga clínica y, al igual que la invitada, especialista certificada en Child Life, entre otras cosas. Y por más de 14 años he trabajado en el ámbito de la salud, sobre todo en el ámbito pediátrico, brindando atención y apoyo a pacientes y familias que enfrentan situaciones médico-hospitalarias, formando psicólogos hospitalarios y además brindando entrenamiento a profesionales de la salud en técnicas psicosociales para el manejo integral de los pacientes, de los pacientes y familias. Y dada la situación actual que estamos viviendo, desde CENEPAS consideramos sumamente importante difundir conocimiento, para lo cual hemos realizado una serie de webinars y entrevistas dirigidas pues a todo el público y justamente para difundir este conocimiento, además de desarrollar diversos materiales en apoyo para pacientes y familias ante esta situación. En continuidad con este objetivo de seguir difundiendo conocimiento, es que el día de hoy tenemos una invitada muy especial a quien le doy la bienvenida y quiero presentarles. Hilary Woodward es una especialista certificada en Child Life que trabaja actualmente en medicina de emergencia pediátrica en el Hospital de Niños New York Presbyterian en el Centro Médico de la Universidad de Columbia. Ella es también profesora adjunta en Bank Street College of Education y expresidenta del programa de mentores de la Asociación de Especialistas en Child Life, directora de Child Life en Basecamp, que es un programa de entrenamiento interprofesional y basado en simulación en medicina pediátrica de urgencias. Hilary ha presentado su trabajo en simulación, debriefing y manejo del dolor pediátrico a nivel regional, nacional e internacional. Entonces, pues le damos la cordial bienvenida. Welcome, Hilary. Thank you so much for taking the time to be with us today, teaching the webinar Child Life in the Time of COVID-19, live from New York, to share your knowledge and experiences regarding psychosocial interventions with pediatric patients and families in the face of the pandemic. First of all, I want you to know that we've all seen what's going on in New York through the news, and we all feel for the New Yorkers and what all of you are experiencing at this time. And I want to make a special recognition for all of the healthcare workers and the amazing work you're all doing every day, especially Child Life, of course, which always stands a fundamental role in advocating for the needs of pediatric patients and families. So thank you very much, Hilary. And having said that, I will give you the word, and so we can get started. Thank you very much.
Sure, thank you all, and I'll extend the thanks back to you. It's been a privilege to hear about some of the remarkable work that all of you are doing to help patients and families in your local communities as well, and it's truly an honor for me to be able to share with you, and I'm looking forward to the discussion and hearing more about how we can all help support and learn from one another. So this is my hospital home. This is the Pediatric Emergency Department of the New York Presbyterian Morgan Stanley Children's Hospital, which is part of Columbia University Medical Center. If you've ever been to New York, or if you've ever seen Times Square on the news, that's what they often show of New York. And if you're standing in Times Square and you walk straight north about 120 blocks, you will hit our hospital. We are in the very northern part of the island of Manhattan. And typically we see approximately 55,000 pediatric patients per year in our emergency department. So we're a fairly busy place. This is a photo of us right now as we are transitioning into assisting children and families during this pandemic. We've had to expand our spaces in some ways. So this is actually a tent that was pitched outside of our ambulance entrance so that we could accommodate more children and families. The happy news is that now, as in New York City, we've come over the peak and we're starting to gradually see a bit less cases. They've actually been able to take our tents away, but our adult emergency departments are still using tents to help expand their capacity. And as we go, I'll talk more about some of the other adaptations that we've been taking to accommodate and care for our patients and families as best we can. And I'm excited to discuss and hear more about what you are all doing too. So something that's been helpful to me through all this time, and something I wanted to start with, is that I think a lot of the qualities that are required for the types of work we do and that we all already possess are the exact qualities that have helped us to get through this time so far. So being creative and being flexible, something that we all have to do in our work with children, and that's been really key during this time. Another piece that's helped is working with our interprofessional teams, our doctors and our nurses and our respiratory therapists, social workers, to solve the challenges together as they come up. It's helped me to remember that I don't work in a vacuum. I'm not an island by myself. I have a lot of other people with various types of expertise who are there to help. So if we work together, it really makes a difference for our patients. There's a lot of information. We were speaking about it as some of you came on, that everything is changing every day for us here in New York, and I understand for all of you as well. So there's always a lot of new information and things to process. And the more we all keep our eyes and ears open for the different things that we might hear, and then sharing that with our teams and figuring out ways to problem solve, can really help. Something else that's also been challenging is that sometimes there's not a direct answer for the questions we want. There's the expression, it's not black, it's not white, it's gray. And for us, there's a lot of gray. There's a lot of this in between and trying to figure things out. So it's been a bit of a shift and a challenge to learn to just sit with that and sit with the unknown. So our life in our pediatric emergency department right now is really thinking from a disaster medicine mindset. So for the past 6 to 8 weeks or so, we've really functioned as being in the middle of a disaster. And essentially what that mindset is rather than thinking about how we can try to care for patients in the way we usually do and the way we were used to before March of this year, we've had to think about how we can make the resources that we do have stretch as far as possible. Because as you've all seen in the news, the healthcare system in New York is stretched far past. Many weeks ago, we passed the point of being able to do for every patient and family what we would hope to do or be able to do on a typical day. So now it's about how we can make what we do have go as far as possible and to be able to do the best that we can. Another adjustment has been to keep everybody safe by assuming that every patient that we see and every caregiver who is accompanying them has COVID-19. That's not true. Sometimes definitely we're interacting with people who don't have the virus, but in order to keep everybody safe, we treat each situation as though they do have it. So for all of us, when we are at work at the hospital, we wear surgical masks at all times. And when a patient or a caregiver come into the hospital, they are given a mask to wear as well, both the child, if it's age appropriate, if they're a preschooler or older, and the parent or caregiver. For us as a team, we also each have a pair of goggles that we add when we're in direct contact with the patient and family in their exam room. And truthfully, more recently, we've expanded to using gowns and gloves for every patient, even if we don't have a high suspicion that they have COVID-19, but if we are having an extended encounter with them or a longer interaction, like a medical procedure. In the cases where a patient has symptoms of COVID-19, so this could be fever, cough, difficulty breathing, stomach distress, diarrhea, loss of taste or smell. In those cases, we limit interactions in the room, in the patient's room in the emergency department to essential only. So often that means that the child life specialist, me, doesn't go directly into the room, but provides support to the patient and family in other ways. For us, it's primarily been using different options for telehealth, which I'll talk a little bit more about shortly. But generally speaking, the goal is to cluster care. So even nurses and doctors are typically not going in and out of the room very much. They work together as a team to figure out what it is that the patient needs, and then to try to accomplish all of that in one encounter whenever possible. And this both helps keep our staff safer, and it also helps conserve our personal protective equipment, our PPE. We are testing every patient that is admitted to our children's hospital for COVID-19, and we're also testing additional children for the disease if it would change the management of their condition. So an example is children who have cancer, who have symptoms of COVID-19 are being tested, even if they don't initially require hospital admission, because that might impact when they get their chemotherapy or how their condition is managed. In some cases, we have had reason to think that maybe an initial COVID-19 test might have produced a false negative, like where the test comes back negative, but the child has symptoms that are very, very consistent with the presentation of COVID-19. And in those cases, we've often opted to continue using the precautions just as an added layer of safety and protection for everybody involved. Like I said earlier, there's a lot of gray, so it's hard sometimes to determine what exactly is the best based on a policy. So everything is a constant risk-benefit analysis of looking at each situation somewhat individually and figuring out how we can maximize safety and maximize benefit for the patient and the staff. We've definitely had changes in our patient flow, and one of the things that's happened with us is that we're seeing fewer pediatric patients overall right now than we typically do at this time of year. So we actually have fewer children in our emergency department on a day-to-day basis than we usually do, which is interesting and something we didn't necessarily expect going into this. But as this has happened and as our stock of personal protective equipment has increased, the hospital has encouraged us and allowed us to use the N95 masks more frequently as an added layer of protection when working with patients who may have COVID-19. So that's something that has shifted for us since we began this in March until now, of using that type of equipment a bit more often. And we're always learning new things. Again, to go back to the point about how things always change, there's always something new to learn and some new option. And something that I found really helpful is to try to learn the different guidelines that are being shared, even if it seems initially like they might not apply to my role. The photo here is actually this, we got an in-service regarding a pretty cool device that actually creates a negative pressure environment over a child's stretcher, over a child's bed. So there's a blue fan attached to the back of the stretcher, and then you cover it sort of with a plastic tent, and then that allows us to transport children with COVID-19 safely from one area to another if it's not appropriate for them to wear a mask, or if they're requiring respiratory support that makes mask use impossible. So there's always new things to adjust with. From my role, I got to think a lot about how I would help a child cope with sort of being placed in a tent like that, and how we could make it more fun and more less scary. Right, so I understand that parent caregiver presence is a challenge for many of you right now, and that many hospitals are struggling with trying to figure out what to do to keep everybody as safe as possible regarding parents and caregivers of children and whether or not they can or should come to the hospital with their children. In our hospital, all of our pediatric patients may come with one healthy adult parent or caregiver. So that adult can be the biological parent, but if the parent is ill and it's not safe for them to come to the hospital, the family can designate somebody else in their life who they trust to accompany their child to the emergency room and then to be with their child if they are admitted to the hospital. As I mentioned earlier, every parent and caregiver must wear a surgical mask when they are at the hospital at all times. They can take it off briefly to eat or drink, but otherwise they need to wear it all the time, just like we as staff do. There have been situations where we've been able to make exceptions to allow a second parent or caregiver to come and also be with the child. So some examples of this that I've had in my practice are, we've cared for some children who were diagnosed with cancer in our emergency department since this pandemic started, and it was a new diagnosis. They were coming into the emergency department previously healthy with no medical problems, and then the diagnosis was confirmed while they were in our care. So in those situations, if they are cared for by two parents, typically, we were able to bring the second parent in so that both parents were able to hear the diagnosis, speak to the doctors directly, and support their child and support one another. Another example is at the end of life for children who have died since the pandemic started, regardless of whether or not they have COVID-19, we have been able to allow both parents, again, if they have both parents in their lives, to come and to be a part of those end of life care meetings and to be with their child when they died. I've noticed in my own practice that there's been the obvious emotional benefits to all of this. I think we all are very familiar with those from our regular day-to-day work. But there's also been some safety benefits I've noticed. At least in our hospital, if a child is unaccompanied and they're a younger child, like under the age of 8 years old or so, for safety reasons, they have to have a staff one-to-one. So somebody who is able to sort of keep an eye at all times and make sure that they're safe. When the parent is there, we don't need to do this. So it limits the staff exposure to a child who has or may have COVID-19, which is very helpful. And even just with the amount of tasks that young children in particular need assistance with, having the parent there and performing those tasks, again, minimizes the amount of time that the staff has to be in the room. So an example is most parents are used to giving their child oral medications at home. So when a child with COVID-19 has had to take medications, a lot of times the nurse is able to just pass the medication into the room to the parent, and they assist the child in taking it. And then that limits the amount of PPE that has to be used and limits the staff exposure. And the same thing with other tasks like using the bathroom, changing a diaper, meals, drinking, bathing, all of those things that children have to do and can't do independently, that the parents can assist them with and limit the staff exposure. We also have a hypothesis, I guess, we don't know for sure, but it seems like it would make sense that when the patient is more comfortable and in less distress, that might also mean less risk of aerosolization. And aerosolization of the COVID-19 virus can make it much more easy for it to pass from person to person. And the guess is that that happens when there are a lot of droplets from the patient that are released into the environment around them. So our guess is that if a patient is calm and comfortable, they are better able to tolerate wearing the mask, which definitely decreases the risk of transmission to staff or to others around them. And if they're calm, they're not crying, they're not sputtering, they're not screaming, that's less droplets that are going out into the air around them and hopefully less risk of transmission to another person. We've also been fortunate that here in New York, our state government has been supportive of parents and caregivers being present for pediatric patients. So last month, our State Department of Health actually updated its policies to require all hospitals in the state to allow adult support people for certain categories of patients. So one category is pediatric patients, and our policy in the hospital is in line with the state guidelines. So every child in New York State has the right to have an adult support person from their family with them at all times. And for children who are in the hospital for a lengthier period of time, a family can choose 2 healthy adult support people who alternate. So if one adult goes home, the second adult can come and be with the child, and they can go back and forth as long as they both stay healthy. The policy also applies to women who come to the hospital while in labor. Last March, my hospital system and one other system, for a period of a few days, actually had a policy prohibiting laboring mothers from having a support person with them in the delivery room. And that was very controversial and very emotionally distressing to many of us here and to many of the women who are served by our hospital. And it actually resulted in petitions from people all over New York and all over the United States saying this is wrong, we don't think this is ethical, we need to provide a different type of care. So the government actually intervened and said that all laboring mothers have a right to have a healthy support person, and every hospital is required to abide by that. And so our hospital and the other system immediately changed the policy and put some new guidelines in place to help increase safety. One of those guidelines is that all support people have to be screened for symptoms of COVID-19. whether they're accompanying a child or a laboring mother. So their temperature is checked when they enter the hospital, and if they have a fever, they're not permitted to come in. And they're also interviewed and asked about the other symptoms like cough and difficulty breathing. And then for those who stay with an admitted patient, the symptom screening repeats twice a day. So every time the nurses change shifts at 7 a.m. and 7 p.m., they recheck the support person's temperature and they ask them about any symptoms. And if any symptoms appear, then the person needs to leave the hospital immediately. But they can be replaced by another healthy adult as designated by the family. And the link that's on the slide, and can feel free, I'm happy to share the slides with anyone who would like it, but that actually links directly to our state government policy. I mentioned earlier that to cluster care and to try to minimize direct contact, we've started using different kinds of telehealth models whenever we can. So the model that I most often use in my practice in the emergency department is actually very low tech. What our hospital did is in every exam room, they mounted a phone on the wall. So it's a very old-fashioned phone with a cord that has the phone number, as you can see on the slide, posted on a label right outside the room. So when a family enters our emergency department, we bring them into an exam room and we let the parent or caregiver know that when the phone on the wall rings to please answer it. And so the first thing that happens, unless the patient is in distress and needs immediate medical attention, is that the doctor actually calls the family on the phone and they introduce themselves and they get the initial medical history and information about why the patient is coming in that day. So for all of that verbal, that talking part of the encounter, they don't have to do it face-to-face. So there's no exposure and there's no risk. And then they go into the room after that to actually examine the patient. And once they make their plan of care, then the others on the team, such as myself, if we're going to be involved or if there's a need for us, we're able to also call the patient and family on the phone, introduce ourselves, and in my case, work with them to see what would be most helpful to assist them in coping with the plan of care and what will happen next. Something that's been helpful to us in orienting families to this process is first just to let them know what to expect when they're coming into the room and that we'll be using the phone to speak with them first. And it's also been helpful to have some signage by our phones just to help the patient and family know how to operate it and have a little bit more written information immediately as to why we're doing this, although we do make sure to repeat that we're doing this for everybody's safety. It limits our exposure to the patient and also means that the patient has less exposure to each of us. We also have some more high-tech options. These are telehealth carts that have video cameras on the top, and they're made by a company called American Well, and they connect to an app called Touchpoint. So we've each downloaded our app onto our smartphones. We also have a couple iPads in the emergency department for this purpose if needed. And you're able to roll the cart into the patient room. And then once you log into the app, you can communicate with the patient and family that way. So they can see you on the video and you can see them. And you can actually use the app to move the camera back and forth so that if the child is active and moving around, you're able to manipulate it so that you can still see them and talk to them. For our inpatients, this is not the area where I primarily work, but I've been able to do a little bit of this and to work with our team on it. We've used all different video chat apps for virtual sessions. WebEx is the one that we use the most frequently. Our hospital likes that one because they feel it's more secure than some of the other apps. But at least in the United States, although in a regular time, we wouldn't be allowed to use apps like Zoom or FaceTime because they're considered not secure enough and it would be a violation of patient privacy. Now, since we're in a disaster situation, our government has given permission for them to be used to work with patients and families as long as the family consents and says it's okay with them to use those. So the common apps are also in place if that's what the family prefers. Our hospital also has a closed circuit TV setup. So our child life team is doing interactive programming via television for all the patients in the hospital at least 3 times a week. We're used to doing playroom sessions and events with people together, but since we can't do that right now, it was important to us to have other options for the patients to interact with us and with each other in groups. So we're using our TV system for that. One thing we've had to be mindful of is what types of devices we can and cannot use. When the pandemic started, our infection prevention team was quite nervous about passing a device into a patient's room and then cleaning it and then using it with another patient. Because even though our cleaning policies up until now have seemed to work very well, this is a new virus and we weren't positive that that would work. Over time, it does seem like the typical cleaning policies work just fine for cleaning our devices. So they've gotten a bit more confident with that. And we've also been able to get some devices donated that we use specifically with patients who have COVID-19. And so those devices allow us to communicate with them and do virtual sessions, whether it's a teaching session or a play session or just checking in with them. And those devices also allow them to connect with any family members who aren't present with them at the hospital. For many of our patients who have been with us for a long time, it was a difficult transition to not be able to have their brothers and sisters to come see them or to not be able to have their extended family to come see them. And so we've tried to offer options and support to help them still feel as though they're connected to that extended family. And giving choices has seemed to work really well to help our patients and families transition to this. We give them choices whenever we can as to how they access us, whether it's by a phone call, a video chat. And we've also worked with them to make sure that they recognize that we're still respecting their privacy and confidentiality. So when each of us is working with a patient virtually, we work to make sure that we're in a private space so that anything that the patient shares with us that might be a bit more sensitive is not overheard by anyone else in the area. And we make sure to sort of show the patient and family where we're sitting or to describe it to them and let them know that there's nobody else in our space and that we will pause our work with them if somebody else enters our space. And we encourage them to do the same thing if they'd like. So if a nurse comes in to check in and they're sharing something that's more private, it's okay with us if they pause and then wait until that person steps out before we resume. And with this approach, we've been able to do all sorts of things. We have some patients who have transitioned very well to virtual play sessions. We've done this even with many of our oncology patients who don't have COVID-19, but who, because of their higher risk at baseline, like we don't want them to be exposed to anything they don't have to be. Doing the virtual sessions has allowed our child life specialists to still spend extended time with them without risking passing something along to them unknowingly. Because again, even though we're all wearing the masks and we're using the precautions and we're only coming to work if we feel healthy and don't have a fever, you just never know. And so we are attempting to keep them as safe as we can. So a lot of our patients have really enjoyed these virtual play sessions, and also some of our child life specialists have continued working with siblings through the video chat. If they were working with them in person, now they're checking in with them at home. And sometimes they're able to facilitate a sibling visit with the child life specialist support using Zoom or something like we're all doing right now so that everyone can see each other and participate. So I've been asked a lot what we found helpful in preparing for this, or if I could have a do-over, what I would want to do more of to feel more prepared going into this situation. We got a little bit of practice using the video chat and the phones for our work before this started, but definitely I think more practice, the better. If there's anyone who you are working with face-to-face and you know them well and they're willing to do a virtual session with you just as a try, that was really helpful to us to be able to do that before we absolutely had to do it, because then we were also able to ask our patients and their families for their feedback and what we could be doing better to help them feel more comfortable with the situation. And that's actually how we got a lot of the advice that I shared on the previous slide, by asking patients and families what was important to them during this time. I definitely did a lot of reorganizing of our regular supplies. We have transitioned to just using almost exclusively one-time use items to cut out any risk of accidental transmission if something isn't cleaned as properly as we would usually do. So lots of crayons, lots of Play-Doh, lots of things that we don't need to get back. Also thinking about if there's anything else you need that would support you in your work, and working with your hospitals, your communities to figure out how you can get that. We've been fortunate that we've been able to get some iPads and tablets, but I'm also aware of other hospitals in the area that have done a more low-tech approach. I know one hospital is using baby monitors so that they can actually hear the patient inside the room and hear their needs more clearly, and then they don't have to open the door and go in and out every time to find out if something's needed. And walkie-talkies, we got a bunch of those donated as well, which can be used as another option. Something else that I had to think about, because I work in the emergency department and I support families during resuscitations and intubations, is what the considerations are safety-wise when resuscitating a patient who has or may have COVID-19. And for us in the emergency department, that's pretty much every resuscitation now, because we assume that every patient has it until proven otherwise. And typically, if a patient comes in very sick, the fastest we can get a COVID test back on them is at least an hour, closer to 2 or 3. So we don't necessarily know. But because intubation is an aerosolized procedure, it's very high risk for the providers involved, as is CPR and other types of respiratory support. So the resuscitation actually involves only a few providers, sometimes as few as 3, inside the room with the patient, and the other members of the care team outside the room, and communicating with those inside through phone and through signs that we write on and hold up to speak back and forth, and then to make sure that the people inside the room get the supplies that they need, the support that they need, etc. So for my role as a family support person, I need to help orient families to this process and explain to them why we're doing it this way and how this process is assisting their child, and also help the family to feel involved, but not to, by mistake, get in the way of that communication that needs to happen between inside and outside, because we know that parents want the best for their child, and sometimes with that careful explanation of why we're doing it this way, they can better understand the reasons and then better work with us in a really scary situation so that their child can get the best care possible. Something else that I've thought a lot about since this all started is what all of us already know about trauma and the brain. Impact of this pandemic trauma on not just our patients and families, but also on all of us as a medical staff. We know that when someone is undergoing something that their brain is processing as trauma, there is an impact cognitively, so they might not be able to recall information as quickly as they typically do, and we've certainly seen that. There's obviously a great emotional impact. For most of our team, a lot of us have extended ourselves to work with adult patients and families in various capacities, because that population has so much need right now. And some of the greatest distress for the teams has been working with adult patients who are very sick and who are dying without the physical presence of their families. So being that person who holds someone's hand until they die, or being the person who FaceTimes their family on the phone and helps the family be involved in that dying and end of life process, has had a significant emotional impact on many of us. Everyone's fuse is a little bit shorter, so everyone is a little bit more quick-tempered than usual. Sometimes we're just not as patient as we would like to be because of the stress, and so something that's helped us to keep this in mind and to all do our best to try to keep a positive attitude and give each other some grace when someone's having a bad day. See what we can do to support them. We try not to get our feelings hurt if something is, maybe said in stress that, wouldn't usually be said. And our team is amazing. This hasn't happened very often, but it does help us to sort of be able to support each other to recognize that this is probably what's going on when this happens. There have been some different options for staff wellness that have been helpful. Our hospital did set up a recharge room for staff. This is typically a family resource center, but because we're all practicing social distancing, the parents and caregivers are required to stay in their child's room and not move through the hospital. So since that room is not appropriate for family use right now, they set it up for staff use. And so they set up some recliners for staff that are at a 6-foot distance from one another so people can sit and relax. They provide some snacks and coffee and drinks in there each day so you can come in and get something for free and take a few minutes for some quiet. They got us some aromatherapy tabs that can stick on clothes and that have like a lavender scent if you'd like to relax, or an orange scent if you'd like a little energizing. And there's always a staff member from either child life, from social work, from our patient experience team in there as well. So if someone just needs somebody to talk to and to sort of share a little bit about what they're feeling, there's somebody there who is ready to listen. As an emergency department team, we've all been in group therapy for the past several weeks. Members of our psychiatry team are working with us on this. So we have the option each week to attend group therapy, and the hospital has also offered options for individual therapy and counseling as well. As the weeks have gone on, the group therapy has been less well attended. We have some ideas as to why we think that is, but one of the things we're currently doing is reassessing what the needs are and figuring out how we can offer wellness options for people that are more in line with what they need. It also sounds a little bit silly, but honestly, the food really helps a lot. The hospital has been working with the wider community to secure donations of food, and I think they're using some of their own financial resources when possible also to make sure that there's always food available. Because of the pandemic, a lot of the restaurants around the hospital are closed, or it's difficult to get to them when you're working, and they figured out quickly that it wasn't helping anybody to be working hard and feeling hungry at the same time, so they're trying to provide us those options whenever they can. And there's a lot of informal effort between all of us. We have many group texts back and forth where we check in with one another. We call each other. We have TV watch parties together virtually. You know, we try to do a lot of different things to check in with each other and support each other. I don't know if any of you have seen in the news, we are going through as a department right now. Unfortunately, yesterday we learned of the news that one of our colleagues over in the adult emergency department actually committed suicide as seemingly a result of the stress of this pandemic. This was not a person who had a history of mental health problems prior to this. So this is something our department has really been struggling with over the past 2 days, to have somebody who we knew, interacted with, and worked with, who we didn't know was struggling in the way that she obviously was. How we can sort of improve the wellness for everybody. I will say again, like the distress of really working with people who don't have their families with them and who are very, very sick and dying is something that people cite over and over again as one of the hardest parts about this. So I certainly, again, I'm so grateful for all of your advocacy on behalf of your patients and families, and I think that ultimately that will be able to help the staff as well. I'm thrilled to take questions. I'm happy to stay as long as is needed to sort of share more and do whatever I can to help you. But again, I just want to extend my gratitude to all of you for all of your support. We feel it from all corners of the world. This photo is one I actually took back in January. This is the view from the top of One World Trade Center, which is the rebuilt our rebuilt tower after we lost our twin towers on September 11th. This is what was rebuilt in its place. And when you're at the very top of that display, you look down and you see this on the pier. And I think it sums up so much about New York. Over the past 20 years, we have so much to be thankful for from the many who have supported us through hard times. And with our resilience and with so much support, we're gonna get through this. So thank you all.
Thank you, Hilary. It has been such useful information for every one of us. I'm gonna make a brief recount of everything you said, and then I'll ask people if they have questions, either to use their microphone or write them down on the chat, so we can all follow this lead and let you know, okay?
Please, yeah.
Okay.
I'm gonna stop the share just so I can see you all.
Of course. Hola, bueno, pues ese fue el webinar. Voy a hacer una breve recapitulación de todo lo que se abordó en el mismo, para que, bueno, si alguien tiene alguna pregunta, ya saben que pueden hacerlo vía chat o desactivar su micrófono. Y bueno, justamente la intención de este webinar era saber más información respecto, ahorita en este momento sabemos que Nueva York es el epicentro de la pandemia a nivel mundial, pasó a serlo, y justamente nuestra intención ha sido investigar qué está pasando en hospitales pediátricos y, bueno, tuvimos este acercamiento con Hilary para poder ver cómo precisamente están adaptando sus intervenciones y no solo eso, sino también la infraestructura. Entonces, una de las primeras recomendaciones que ella nos dio en este seminario es que cualquier persona que llegue al hospital tiene que se le tiene que hacer la prueba para justamente asegurar si es COVID positivo. Y en el caso de niños y sus cuidadores, no podemos asumir que unos sí están enfermos, que otros no, sino que a todos se les debería hacer la prueba y el personal tampoco se puede confiar. El personal tiene que seguir usando el equipo de protección, aunque no haya sospecha de un diagnóstico de COVID-19. En su hospital sí está permitido la presencia de un adulto y esto es algo de lo que nos habló mucho, que fue que en el estado de Nueva York inicialmente los proveedores de servicios de salud, los hospitales, emitieron algunas recomendaciones o algunas políticas en donde no se iba a dejar a los pacientes estar acompañados de un cuidador y esto aplicaba para pacientes pediátricos y para mujeres en labor. Y justamente muchas personas empezaron a abogar por esta situación. Se cambió la política y actualmente en todos los hospitales se está permitiendo que las mujeres en labor estén acompañadas de un adulto y los niños tengan 2 cuidadores designados, uno a la vez, pero para poder intercambiar lugares tienen que hacerlo fuera del hospital y obviamente reevaluar al otro cuidador y asegurarse desde que no tenga fiebre hasta hacer la prueba para asegurarse de todo esto. La importancia de tener obviamente a un cuidador con el niño, que es algo controversial todavía en México, que no sabemos si se va a permitir, aunque algunos colegas estamos trabajando precisamente y arduamente en un documento para poder tener toda la evidencia científica de por qué es importante, y Hilary nos compartió esta parte, que una de las cosas más importantes es la disminución del riesgo del personal, porque si hay familiares que se hagan cargo de cubrir las necesidades básicas de los niños como alimentación, el baño, darles las medicinas orales, eso va a hacer que el personal no tenga que estar tan en contacto con el paciente infectado, sino que sea el cuidador quien lleve a cabo todas estas funciones, además de que en su experiencia, en su observación del día a día, han visto que esto también reduce el riesgo de estar expuesto a aerosoles, gotas, secreciones por parte del niño. Si el niño está inquieto, si el niño está llorando, va a ser más difícil que acepte usar un cubrebocas o acepte seguir las indicaciones de los tratamientos que tiene que seguir, y entonces eso pone al personal, por supuesto, que mucho más en riesgo que de no tener un cuidador, ¿no? Otras cosas que ella abordó es la parte de la adaptación de la infraestructura. Como pudieron ver en una de las imágenes, uno de los cuartos de urgencias se adaptó precisamente para que el paciente llegue ahí, el que podría ser portador de COVID y con su familiar, y tienen un teléfono designado para recopilar toda la historia clínica del paciente y los datos que se necesitan vía telefónica, y eso hace que obviamente la interacción con el personal sea menor. Y toda la parte de tecnología que tienen en este hospital, de telemedicina, de usar tabletas y celulares. Entonces, ya si el paciente está hospitalizado, están usando estos carritos que vieron en la tele de telemedicina, en donde el carrito se ingresa a la habitación, pero el personal desde fuera, desde el exterior, se conecta vía tableta o vía celular. Para poder brindar pues, las indicaciones necesarias con ese paciente y su cuidador. Tenemos que considerar, sin embargo, la parte de la confidencialidad, que también se me hizo muy importante en lo que ella mencionó, el hacer telemedicina, el hacer sesiones virtuales con los pacientes o intervenciones virtuales, implica que tenemos que cuidar mucho más esta parte de la confidencialidad, porque el paciente pues nada más nos ve en la cámara, pero no sabe quién podría estar alrededor, y ella resaltaba mucho esta parte de justo asegurarles que sigue siendo un espacio seguro. Si la enfermera entra o si la enfermera está haciendo algún procedimiento, bueno, se interrumpe la sesión y se retoma una vez que haya otra vez privacidad. Las sesiones virtuales a través del juego, que ahí, no sé ustedes, pero a mí en lo personal me gustaría saber un poco más qué tipo de sesiones hacen y qué tipo de actividades con los pacientes, así como el trabajo con los hermanitos también. Reorganizar pues todos los recursos que se tienen en esta época. Sabemos que los recursos son escasos y hay que reorganizarlos de la mejor manera. y todas las implicaciones del trauma, ¿no? El trauma para el personal que todos los días está en contacto con el dolor, el sufrimiento, la muerte, ver pacientes muy enfermos que mueren y muchos de los adultos que están viendo que mueren sin compañía. Todavía en algunos lugares esto está sucediendo. Entonces, pues esa carga emocional que esto representa es muchísima para el personal y nos compartía pues esta noticia con la que el día de ayer y hoy también pues nos despertamos algunos, que fue la muerte de esta doctora por suicidio. Se suicidó una doctora que era jefa del servicio de urgencias justamente del Hospital Presbyteriano de Nueva York. Y pues ahí estamos viendo el terrible impacto que esto está teniendo en los profesionales de la salud y la necesidad no solo de trabajar con pacientes y familias, sino con el personal. Y ella también ofrecía como, justo ahorita nos compartía más bien opciones para el bienestar del personal a través de diversos recursos que han destinado para el que el personal esté lo mejor posible a nivel salud mental, como es este cuarto que me encantó el concepto del cuarto para recargar energías, que era un cuarto originalmente destinado a pacientes y familias para que pudieran tener un espacio seguro y con snacks, con café, con aromaterapia y con recursos para que el personal pueda recargar energías ahí, sentirse seguro y con la presencia de un trabajador social, un especialista en Child Life u otro especialista que puedan también ayudarlos si es que el personal quiere desahogarse y quiere expresar sus emociones, terapias de grupo y otros esfuerzos individuales. Entonces, bueno, creo que fue muy, muy rico este webinar. Estoy viendo en el chat ya un comentario de Telma. Telma have you seen her comment on the chat?
Do you want to share with everybody else and I'll answer?
Yes. So Telma is sharing. Telma nos comparte que congratulations. Do you provide emotional support for children whose parents, at least one of them, has COVID-19 and it is at the hospital? O sea que si también brindan apoyo emocional a niños que sus papás, al menos uno de ellos tiene COVID-19 y tiene que estar en el hospital.
Yes, so thank you, Thelma, for the question. Yes, we do. So we as a Child Life staff have reached out to the staff on the adult teams and reminded them that we are pleased to offer this service to any family who they feel could benefit. In my case, the families of adult patients I've been working with have mostly, the patients are mostly older, and so their children are mostly adults as well. But I did work with one family who the patient was younger and had two school-age children, and the patient's spouse was struggling with how to speak with them about what was going on, and the fact that the patient ultimately, unfortunately, died. That was very challenging for them as a family. So in that particular case, what worked for the family was for me to actually work with the patient's spouse and to support them in different strategies they could use to support themselves and their children. But we are open definitely to meeting with children through telephone or through video chat, if that would be helpful. I think you're still on mute.
Justo compartiendo su experiencia, gracias. Thank you, Hilary, for sharing that experience and that specific case. La experiencia de los especialistas en Child Life siempre intentamos apoyar también a los hijos de pacientes adultos o niños en cualquier situación médica hospitalaria que requieran apoyo, precisamente para ayudarlos a entender lo que está pasando y hacer estas preparaciones o inclusive facilitar despedidas entre la persona y el niño, o sea, la persona adulta que va a fallecer y el niño. En este caso, pues obviamente adaptadas las intervenciones muchas veces en la parte con la tecnología, porque no siempre se está dejando a la familia entrar, pero bueno, se han propuesto y espero poder organizar otro seminario con este tema, cómo facilitar este tipo de actividades para duelos anticipados en esta situación. Gaby, creo que querías preguntar algo, si quieres preguntarlo en alto, perdón.
Hi, thank you so much, first of all.
No te oímos muy bien, más fuerte.
So first of all, thank you so much for sharing with us. Also, I'm sorry for the loss of your coworker. I know it's probably very, very hard right now. I was wondering if the patients that do stay at the hospital right now, because you're not able to give them all the toys and everything that you usually do, if you encourage them to bring them from home. I don't know if the infectious part of the hospital is allowing that. So if there are items like to help them cope right now.
Yeah, that's a great question. Yes, they are allowed. The hospital allowed that previously, and they haven't made any changes to that, which has been really helpful. So the patients and families are welcome to bring any favorite toys, technology, comfort items from home.
Thank you.
You're welcome.
So we have another question. Humberto Bautista is asking, how many suicide attempts have you had with teens with cancer disease and COVID-19?
So to my knowledge, we fortunately have not had any from teens with both cancer and COVID. We actually were guessing when the pandemic started that we might see more suicide attempts with adolescents in general, just because of all the changes that are happening in our city. And we were thinking, maybe teenagers might feel more isolated. They might feel more stressed. Maybe they're away from their friends or their teachers or their usual types of support if they're having a hard time at home. Unfortunately, I'm going to be superstitious and knock on wood. We haven't seen that too much. We have seen some patients with mental health concerns, as we always do, but at least so far it hasn't been too bad.
Okay, great. And I would also want to know about the virtual play sessions you were mentioning, Hilary. What kind of play sessions, what are you providing right now for patients virtually? I think we will all benefit from a couple of options and ideas.
Sure. One thing that's worked well is medical play. So the same materials that you might usually use, maybe a doll, maybe medical supplies that are safe for the patient to handle by themselves can go into the room, and then the tablet or device can be set up so that the child life specialist can see the patient and narrate the play that they're doing. So the same child-centered approach that we might use to support a patient in their exploration. For patients who are about, I would say, 6 or 7 years old and older, that has tended to work pretty well. Our team has had a bit of a harder time sometimes with it with younger patients because virtually the attention span is a little bit different. But for older patients, it's worked well. And then for other sessions, sort of more free play with supplies that the patient enjoys. Art activities have worked well with some patients, having the art supplies go into the room and then narrating as the patient creates something has also worked well.
Amazing, amazing. We have another question from Ale Fierros. Excellent sessions. I don't know if it's part of your work area, but do you have any knowledge about how is your hospital handling visits at the NICU with babies which are COVID, which might be COVID positive?
Yes, so this has been a challenge for us for sure. So when the pandemic started, the first step was the NICU put into place a one parent per baby policy. I actually have a friend and coworker who was in the NICU with her child at the time, and it was very difficult because then her partner could no longer come. So the families had to just choose one parent. I think some of the reasoning behind that is because in our NICU, it's very large, and so parents cannot stay over with the babies. So parents are coming and going from the hospital every day, and so they wanted to minimize the risk to the babies in that area. So one parent was able to come, but it just had to be the same person all the time. Now, as the pandemic has continued, we've had the challenge of mothers who come in who test positive for COVID-19. So one of the things that's happened is in our mothers unit, every woman who comes in to deliver is tested for COVID-19. And we've had quite a few women test positive, and about 15% of them or so are, or no, that might be more than that. We've had 15% of all the women who deliver test positive, and 90% of those have been completely asymptomatic. So they don't have a cough, they don't have a fever, they don't have any other symptoms, and they did not know that they had COVID-19. For their babies, if their baby is healthy, the mother is able to interact with the baby as they usually would, with a mask on to help protect the baby. If the baby needs to go to the NICU because of another health issue, that baby is treated as a COVID PUI or as a patient who might have COVID-19. And until the baby is 14 days old and then tests negative at day 14, they are considered to have COVID. And because the mother is COVID positive, the mother is not allowed to then visit them in the NICU until she clears the virus. So in those situations, the family can designate another healthy caregiver to visit the baby. And our child life staff in the NICU has been helping facilitate video visits between the mother and the baby, the siblings and the baby, and others who can't be there. So they're using WebEx mostly, but other video chat apps, so that every family can see their baby every day.
Yeah, I actually saw today some news in a hospital in Spain, in Barcelona, that yes, a mother tested positive, she gave birth, and then they took the baby, but they were doing these virtual sessions for her to meet the baby. Some nurses were taking care of that because she was COVID positive and couldn't see the baby. The baby was fine. So thank you for that. We have some more questions. How many pediatric patients have had to stay at the hospital because of COVID?
So as of, I want to say about 9 days ago, our inpatient hospitalist team was estimating that they've admitted about 50 patients with COVID-19, but not all of those patients have been under the age of 18. Because we're helping our adult services, they've also been taking care of some young adult patients. So I'm not sure how many patients on the service are actually pediatric. My estimation is it's no more than half.
Okay. Still a lot.
Yeah. For the vast majority of children, though, like we've seen more in our emergency department, and others are, able to stay home. Like for most children, it seems like their experience with the virus is much more mild symptoms than most adults are having. We have seen a handful of children get very, very sick and require intensive care, but that's not the majority.
Okay. Thelma has another question. How can we cope with the emotions of children whose parents work at hospitals?
It's a hard one. That's a hard one for sure. What I and some of my colleagues in child life elsewhere in the city have tried to do is to provide resources to the children's parents when we're interacting with them in the hospital of how they might talk about what's going on with their children. From listening to some of my colleagues who are parents, it's very challenging. The children, especially those who are older and who are hearing what's going on in the news, certainly have worries about their parents, and they're also dealing with all of the other changes in their lives right now. They're not going to school in person. They're doing online learning. They're not able to see their friends. So that's resulted, I think, for many people in all the things we would expect. The children, maybe they're crying more often, maybe they're getting in fights with their brothers and sisters more often. They're sort of showing those emotions in different ways. And so for their parents, validating that these things are to be expected and working with the families to find ways to have some dialogue and to support each other, I hope has been helpful. But it definitely is a big challenge for sure. And I'll also say some of the other emotional challenges, at least here in New York, and I don't know if this is the case elsewhere, some of my colleagues with children have decided to live apart from their children during this time, either because they're working a lot and maybe the child has another close adult in their life who can give them more attention and support during this time. Others have children who have other medical issues, and so they feel worried about maybe bringing COVID home to their children. And so it seems to be, they feel like it's a better solution for the children to live apart. But others haven't made that choice. Others are living with their family as they usually do. So maybe also knowing the situation of what the family has decided for themselves, because the support might look a little bit different depending on what's going on.
Yeah, many healthcare professionals have taken the same decision here in Mexico, and some hotels are starting to offer the option of them staying there so they could keep their family safe.
Yeah, and I have colleagues who also live with, older adults as well who've made the same choice for that reason. Maybe they live with somebody who's at risk. And so similar, like our hotels in New York are helping, and also the dorms at our university at Columbia have also been open to anybody who feels safer living apart from their family right now.
Yeah, and we also, like through the center, we developed a resource for children of healthcare workers in which we explain their role, and offered some connection activities to, feel connected with them while they're at work and know that they're safe because they're using very specific protection equipment, even though it's in some places it's scarce and few, but anyways, we developed that for that purpose. There's another question. Have you had knowledge of healthcare staff that because of being in contact with patients with COVID have, get sick?
Yes, unfortunately. Not as much in pediatrics, fortunately, but in adult medicine, especially in the adult emergency department, quite a few of them become sick from COVID-19. Most have recovered well. Unfortunately, we have had across our hospital system about 15 deaths of hospital employees from COVID-19. I will say the community spread in New York is so great right now. Like the risk of getting COVID-19 outside the hospital is also still present. So we really can't know, exactly how anybody got the disease. But certainly when working in adult medicine, the exposure is very, very, very high. So the risk can be quite high.
Regarding that, a lot of my colleagues have been very worried about exactly what kind of protection equipment. I think you mentioned it during the presentation, but they're still very worried about what kind of protection equipment will the caregiver be needing during this time, and if there's a brief training for families about safety measures in this regard.
So for the caregivers, we require them to wear a surgical mask at all times, both for their protection and for ours. For the most part, the caregivers live with the children who come in, so they likely have been exposed to the disease throughout their time caring for the child at home before the admission. And in many cases, the family already knows that either they've been sick and recovered, or there are others in the home who are sick. So at least in my experience, I haven't run into it as a big concern of the caregiver, just because the exposures have already happened. So then it more so just becomes a matter of how we maintain as much safety as we can. So definitely providing the mask, showing them how to wear it correctly and safely. Our nurses are pretty good about sort of like when somebody, for example, in the emergency department, we don't have bathrooms in every room. So since the caregiver is healthy, as long as they wear their mask, they can step out of the room to use the bathroom and then come back. But just providing education to people in real time about okay, please don't use the gloves, but please wash your hands before you leave the room, wash your hands after you use the bathroom, and then come directly back in. Sort of education like that in real time to help maintain safety is what we've been doing. But there's not a formal process or anything formal that they have to sign or like that.
Okay. Yeah, because even though they might seem like basic measures, we cannot just assume they will follow them, right?
I will say for the most part, everyone's been really cooperative. They want to be able to be with their child. So we haven't really had a lot of issue with it being followed. Where people have been more resistant is the one visitor policy. That's something that a lot of families have struggled with. But for safety, unless it's an extenuating circumstance, we have to enforce it.
Okay. And to start close today's webinar, Hilary, I would like to ask what are the primary interventions for COVID-19 pediatric patients besides the play sessions you mentioned before, but what would you consider to be the most important interventions for these patients?
Oh, that's a great question. I think one has definitely been, especially for the older patients, like the school-aged and the adolescent patients, validating the anxiety that comes with not being able to breathe very well. And that's something that once the child is at the point of needing to be admitted, all of our patients are experiencing. So they might be awake and they might, have the appropriate oxygen and everything they need, but they feel as though they're really struggling to breathe. So I've done a lot of validating that's really difficult. And of course that would make anybody nervous. But that also is part of this illness. And as the illness runs its course, that will get better. So let's think about ways to help cope with the distress that comes along with that. And distraction works well. Meditation or guided imagery can work well. Anything that sort of helps them focus less on the sensation of trying to catch their breath and to bring their focus onto something else. That's been something that has been helpful. And the other pieces, we've continued to offer support for coping with procedures. So for the younger children, certainly the IV placement is still something that's stressful. For some children, having to take the breathing treatments is something that's stressful. Since we're minimizing our exposure in the room, a lot of that has been me coaching parents in terms of how they can support the child during that procedure. And that's also worked pretty well. You also saw how our exam rooms are. Our exam rooms all have a glass door. So if they put me on speakerphone, I can actually stand outside and do some coaching in real time with the parent during the procedure. Or if the child is old enough, some coaching with the child. So that also actually has worked pretty well because I can see everything that's going on in the room and they can see me. We just use the phone to help us hear each other.
That's very important, I think, for everyone to hear, because we are also assuming that because a patient might be COVID positive, we cannot possibly give any intervention because of the risks, but there are ways to adjust ourselves and provide and adjust the psychosocial interventions as well and be able to provide this care. So it's 2 more questions. Enriqueta is saying, congratulations on the work done and thank you for sharing your experience and knowledge, as it allows us to expand the panorama of possible interventions. So, and there's a question of Humberto. When ventilators have run out, how do you choose the patient to which you can give the other one or the one that is left? And how do you give contention because of the distress of the rest of the families that have to wait?
Yes. So we were very lucky. This did not happen to us. We worried that it would happen, but actually here in New York, we did not run out of ventilators. So that was helpful. I think in talking to just families of the adult patients in general, communication from their team is really important. And one of the things that's helped our adult medicine teams do that really well is to involve the palliative care team. So for all of our adult intensive care patients, palliative care has been involved. We've actually gotten support even from outside New York. We've had a palliative care team in California who is providing consults to families virtually and via phone to help support us to make sure that we can extend that kind of service to everybody. And I think that their expertise in terms of talking with families about goals of care has been really important. In our case, it wasn't important because of a shortage of ventilators, but it was just important in terms of trying to do the best thing that we could for every patient and help families to think about what their loved one would prefer, and then to work with the team to help their loved one have as peaceful an experience as possible.
In Mexico, there have been issued a couple of guides on medical ethics, and they establish certain, one of them has been really controversial, but other institutions have provided other guides and exactly to manage these kinds of scenarios, as well as medical ethics consulting. So if anyone has these dilemmas, there are services already in place to be consulted. So that's very helpful too. And of course, integrate the palliative care team, that's essential. So yes, I skipped a question, so I'm gonna read it right now. In the hospital, do you approach emotional support for staff members? Have they done any proposals as well as the physical space that in which they can rest, but let me read it in Spanish. En el hospital se atiende el aspecto emocional en el personal, pero se han hecho propuestas como el del espacio para que puedan descansar, pero no se ha concretado. ¿Dónde se pueden consultar las medidas que han tomado ustedes para fundamentarlo? Okay, so she's asking that they have tried to make a proposal in their hospital, the same of the resting space for the healthcare staff, but haven't had success in proceeding with it because they need more information or more, scientific background or evidence-based knowledge to be able to support that protocol. So if you have anything to share about the importance of taking care of staff through those resting spaces, that might be great, or recharging spaces that you mentioned before.
Yeah, there's nothing that I'm aware of that I can think of immediately, but certainly if I come up with anything, I'll share with you. I'll share with you via email. I will say that the other thing that they've been doing at the hospital that I think is really important and is supported by past evidence related to trauma is to offer everybody the counseling, the free counseling, whether with a psychologist or a psychiatrist. We all have that option. And I think that's really, really important. So even if like the staff room is something that they feel like they can't approve, can they offer, some other type of counseling?
Okay. I'm gonna ask this person for her email. So if there's something we can come up with, we can email her back. So Moto, si nos puedes compartir tu correo, los demás ya los tenemos, pero como el tuyo no sé quién eres por el nombre de usuario, para poder compartir si es que surge algún sustento en lo que te podamos ayudar con esto, sería excelente. And finally, Hilary, even though you mentioned all these wellness measures that you've been taking for staff, how do you take care of yourself?
So for me, so far it's been a few things. Doing things like this honestly helps. It helps to, be able to share our experiences to hopefully help others. Trying to make as much good come out of a bad situation really helps. It also has been amazing. This situation has been unprecedented. We, have certainly seen a lot of loss, but we've also seen so much kindness and so much support here in our city. At 7 p.m. every night, the entire city applauds for, everybody out on the front lines, and at the hospital, we've gotten cards and letters and really lovely things. And I've just been so humbled by the grace that all of the families we've cared for have shown us. For us, it's been very stressful and we feel like we can't do enough. But my experience so far has been that when we try and when we really put that effort and try to communicate with families well, that it's well received. So that also helps to remember that and to, remind all of us, as we do these things in these hard times, that we really still can make a difference for our patients and families and keep going. And I'm also really grateful for my coworkers, my family, my friends, everybody who checks in. And so I feel like I have a lot of support, and I wish all of that for all of you, and certainly encourage you to keep whoever is important in your life close during this time. When we're not physically together, I feel like it can be a little bit harder to sort of maintain that connection, but to make a point to video chat or to text or to do whatever you need to do to stay connected is really important, and to ask for help if and when you need it.
So yeah, I think I will resume it in having a strong support network, community support, which brings back the sense of that all community are being together, supporting each other. Unfortunately, here in Mexico, we've been having several cases of aggression to healthcare workers. And I think that comes from fear and some other things. So we're trying to direct our efforts to make that better and to prevent that from happening. So anyways, thank you so much, Hilary, for your time today. I think we all enjoyed all of the knowledge you had to share with us. and we'll be willing to stay in touch. And we wish you the best doing the great work you're already doing. So thank you so much. They're applauding you.
I see it. Thank you, everybody. It's been such a pleasure to be here with you. And I'm just so humbled by the amazing work that you all are doing, and would love to hear more about it. I certainly would love to hear from any of you via email if there's more that I can do to be helpful. And I feel like I can learn a lot from your experiences as well. So please feel free to share.
Thank you so much. Y gracias a todos por estar con nosotros el día de hoy. Y bueno, seguiremos seguramente en contacto. Que tengan un muy bonito día y hasta luego. Bye.
Gracias a todos.
Bye.